Hi friends, it's a routine case 62-year female with grade 2-3 cataract and a dense posterior subcapsular sheet. The pupil was not dilating fully, it's a mid-dilated pupil and dilatation is around 5.5 to 6 mm. These are the tricky cases where you have to do the surgery without use of pupillary expansion device or any mechanical stretching of the pupil. Here our main aim is to avoid any endothelium injury and to prevent the rent. As I started the surgery, I made a 2.8 mm posterior limbal incision. As the pupil is mid dilated and I expect it can go down also during the surgery, so we are staining the anterior capsule with tryphan blue. An air bubble helps to avoid any staining of the endothelium. A phenocaine is used, a combination of tropicamide, lidocaine and tropicamide. With the help of visco, we have a dilatation increase up to almost 7 mm. Now it's time to do capsular access with a 26 gauge needle. You can use a capsular access forceps also as per your convenience. As you can see, we are doing the capsular access. Our aim is to have a bigger access, at least more than 5.5 to 6 mm. We have to go behind the iris also little bit, because a bigger axis helps you to have a good dissection and an easy cortical wash at the end of the surgery. Side port was made 4 o'clock hours away from the main port. Few people use MVR. I am comfortable with the lens tip. Now we are doing hydrodissection. In slow motion you can see as we are pushing the fluid, it's going to the other end, and with that we are decompressing the bag also. So you have to do multiple quadrant hydrodissection so that the nucleus is freely movable and the Phaco procedure will be easy further. You can see a tag of anterior capsular stained with blue dye stuck in that section. Visco was injected. Here I plan a direct chop. First, as usual, I rotate the nucleus to make it free from the cortical adhesions. What I planned was to make a trench first, then rotate the nucleus and start with direct chop. Sometimes in hard cataract this thing helps that you can debulk the nucleus by making a trench, and then you rotate. That trench gives you a good hold of the nucleus and you can break the nucleus easily by direct chop that way. But here what mistake I did is, as I am making the trench in Phaco 1, you can see here the vacuum is hardly 40 mm Hg, power is 60. So it's not of full depth. As the posterior capsular cataract was dense, I should have gone little bit deeper in the center of the nucleus to break that thick sheet. It's a partial thickness tunnel. I should have made 80 to 90% of the thickness as planned. As I am rotating the nucleus now for the direct chop, as you can see, this tunnel gives you a good hold of the nucleus. So as I am holding here and breaking, I have tried horizontal chop here, but the problem is the nuclear pieces are joined together from the center, so I am not getting a full break. So I am trying to break it into multiple small pieces. A small chunk of posterior capsular sheet I am able to hold and emulsify it. As the pupil is almost 4 to 5 mm now, so I have to take care that I should not hold the rhexis while pulling out the nuclear pieces. We are in Phaco 2 at present. Vacuum of 380 mmHg, power 60 and flow rate of 40. As we are breaking, we are doing it at the deepest level. Now the pieces are aspirated and emulsified into the center so that the corneal endothelium doesn't get damaged. Here you have to be a little bit cautious that the pieces should not also chatter to avoid any corneal endothelial damage. Half of the nuclear part is emulsified, now it's the other half. Second mistake in these cases, you should always supplement the anterior chamber with visco, but I continued like this. If you are comfortable and you know that the fluidics are going well and the chamber is maintained well, you can also proceed like this, and with experience you can do this. Always keep watch over the section, and some fluid BSS should be poured over the section so that there should not be any wound burn. You have to also keep watch over your dialer position, that should be in center. As we are treating the last piece, care should be taken that this is the place where most of the PC rent happens. So you have to slow and steady at this moment. Don't be in hurry. The nuclear emulsification is almost complete. Now you can see there are some nuclear pieces stuck at the side port. So these in small pupil, as these pieces get support from the mid-dilated pupil, so they stuck at the side port. So you should always release these pieces and remove them. Now we are in Phaco 3 and trying to aspirate the epinucleus, but I am little hesitant that I should not catch the iris because it's very near to the capsular access margin. Few tries. In Phaco 3 our vacuum is hardly 180, flow rate is 25 and power is 25. Visco was injected. I opted for coaxial IA. You can choose as per your convenience, either bimanual or coaxial. There is a thick sheet of epinucleus, you can see. In IA1, my settings are 450 vacuum and 40 flow rate. I'm trying to pull the epinuclear sheet towards the center and then we are aspirating. As you can see, it's a thick epinuclear sheet. As I'm pulling it towards the center, sometimes we can try by rotating around the tip of the IA towards the capsule, but should be careful that it should not catch the PC. Again, I have rotated down, but keeping watch over the posterior capsule also and doing it slow and steady. Should not be in hurry when you rotate the tip towards the posterior capsule. Subincisional cortex is removed. Now the last chunk of cortex is there and we have removed it. Now it's time to put the lens. So first, visco injection was done. Here I am implanting Hoya 150 lens, preloaded lens. One haptic is in the back, other is above the iris. With the help of a dialer, you can rotate it to the back. You should always make sure that both the haptics are in the back. And if you want to check, you can lift the iris and check the haptic position also if any confusion is there. Now it's time to do the visco wash. In these mid-dilated cases or small pupil cases, you can remove the visco behind the IOL by just taping over the IOL, and if you are comfortable, you can go behind also by lifting the edge of the IOL. As you can see here, I am lifting the edge of the IOL, just going behind, putting my coaxial tape there with some irrigation and aspiration. I am removing the visco behind the IOL also. As you can see, the visco is coming out. A good visco wash is done in all the angles. Now the section is formed. Side port hydration is done. Now the case is complete. Thanks for watching.